Hello everyone, this is your colleague طالبة النجيدي. I'm a medical intern, and today we will be tackling a very important topic, which is the reconstruction in plastic surgery. So without further ado, let's get started. So I would like to start off my talk with a quote, which is doubt kills more dreams than failure ever will. So never doubt yourself, always focus on your dreams. Everyone else did it before you, so obviously you can do it as well. So let's talk about the objectives. So the objectives of this lecture includes the general approach to complex wounds, reconstructive ladder, and wound healing adjunct. So first, to understand wound healing, we have to go back to the very basics of wound healing. So we have something called the phases of wound healing, and we have types of wound healing. We will be discussing both in this lecture, so I need you guys to focus on the differences between both. So the phases of wound healing, it mainly consists of 3 phases. Some references say 4. So the first phase, which is the inflammatory phase, also known as the reactive phase, it's going to happen from days 1 to day 6. It's mainly consisting of 2 main concepts. We have the hemostasis, which is where the vasoconstriction is going to happen and the plated plug is going to form. The main idea is to stop the bleeding. The second concept is the chemotaxis. So the chemotaxis, the main idea is that we want the debris and the organisms to be cleared out, and this is going to happen via an inflammatory response mediated by 2 cells. So we have the neutrophils, which are going to present to the scene within 24 to 48 hours, and the macrophages, which will present at 48 to 96 hours. The second phase, which is the proliferative phase, also known as the regenerative phase, it's going to happen from day 4 until week 3. This phase is solely mediated by the fibroblast, which will be activated and attracted by the macrophages. There's again 3 main concepts in this phase. It's the collagen synthesis, which is mainly type 3, and please memorize the type of collagen. It's usually a common question. And then the angiogenesis, and then the epithelialization. The final stage, which is the remodeling phase or the maturation phase, it's going to happen from week 3 until the first year. In this phase, what's going to happen exactly is that we're going to have the collagen reorganization, and there will be stronger cross links. But there are 2 very important concepts in this phase. First, type 3 collagen is going to be replaced by type 1 collagen in a certain ratio. And please memorize this ratio. It's a 4-to-1 ratio. And then the tensile strength is going to reach to its maximum, which is 80% of the pre-injury strength. This is also a very high yield question because after the wound, the maximum tensile strength you can reach is 80% within 60 days, as where before the wound, it's 100%. So when do we interfere as plastic surgeons? Usually we interfere after the remodeling phase. So after 1 to 2 years, if the patient is still not satisfied with the appearance of the wound or the scar or the cosmesis in general, this is where plastic surgeons interfere. Okay, so whenever we talk about a defect and the reconstruction of a wound defect, we have to follow what is called a reconstructive ladder. So what this ladder is exactly is that whenever you want to reconstruct a wound, you have to start with the least complex method, which is in this case healing by secondary intention, to the most complex method, which is the free flap. So I will be talking about each and every one of these in the upcoming slides. But generally, we start with the healing by secondary intention, and then the primary closure, and then the delayed closure, which is also known as delayed primary closure or tertiary healing. And then you have the split and full thickness grafts, and then the random and pedicled flaps, and then the tissue expansion, and then finally the free flap. So let's talk about the types of wound healing. What we tackled previously was the phases of wound healing. Now we're going to talk about the types. So first is the primary healing. So in the primary healing, what is happening exactly, the main concept is that the surgeon is going to approximate both edges of the wound together. And this is going to happen within hours. Okay? And then we have the secondary healing. So in the secondary healing, what is going to happen is that you're going to leave the wound to heal by its own. And this is going to happen by a process of granulation, contracture, and epithelialization. A classical example of secondary healing would be an infected bed sore. What we usually do is that you're going to debride the bed sore and you're going to do dressing. Usually it's daily dressing until the wound heals on its own without any approximation and without an intervention from the surgeon. For the tertiary healing, it's also known as delayed primary closure. Why? Because the main concept is that you're going to debride first and then you're going to approximate the wound edges together. And this is also preferred for contaminated wounds. Okay, so going on to with the reconstructive ladder, we have the grafts. So the grafts are usually tissues that are composed of epidermis and various degree of dermis. Why I said various degree? Because we have different types of grafts that I will be talking about in a bit. So uterine grafts, they do not carry their own blood supply. This is an extremely important point. And this is how you differentiate between grafts and flaps. Grafts do not have their own blood supply, which means that they depend on the vascularity of the recipient site. What do I mean by that? So whenever we obtain a graft, you're obtaining it from a donor site and you're gonna apply it to a recipient site. So if the recipient site was not well vascularized and there wasn't a good uptake of the graft, it's gonna fail because it does not have its own blood supply. So we have two main classifications of grafts. We have the by species or by thickness. Species, we have the autograft, which is from the individual, from the same individual, or allograft, which is also known as homograft, which is from the same species, so from human to human, and then xenograft, which is also known as heterograft, which is from different species, such as animals to humans. By thickness, and this is very important, we have a split thickness and a full thickness graft. So this is a very nice illustration in which you can differentiate between the split and the full thickness graft. Generally speaking, grafts are usually limited to the dermis and the epidermis, so they do not go to the subcutaneous tissue. The subcutaneous tissue is usually spared by grafts. Okay, so in the split thickness, you have three types. You have the thin, medium, and thick. Generally speaking, you're going to obtain the epidermis, and then part of the dermis, which is the papillary dermis and the medium split thickness graft, and then part of the dermis, which is the reticular dermis and the thick split thickness graft. But for the full thickness graft, you're going to obtain all of the epidermis and the dermis with its two layers, the papillary and the reticular. So what are the advantages and disadvantages of both types? So in the split thickness graft, the advantage is that in the donor site, which is the site you obtained your graft initially from, it's going to heal within 7 to 21 days. Why is this important? Because, and usually the type of healing is going to be secondary intention. So why is this important? Because if you need to re-harvest the same site again, you can do so. But the disadvantage is that you're going to have something called an early contracture, or also known as primary contracture. The problem with the primary contracture, what it is exactly, is that in the OR, whenever you obtained your split thickness graft, the second you remove it from the donor site, it's going to shrink. You have to take this into consideration when you're measuring the defect. So you have to know that split thickness grafts are usually going to have a primary contracture. So this is important when you're measuring the parameters of the defect. There's minimal hair growth and minimal sebaceous secretion because you don't have a hair follicle or sweat glands. For the full thickness graft, on the other hand, the advantages are that you're going to have a contracture, but it's not early, it's late, also known as secondary contracture. This happens because the full thickness graft usually has fibroblasts. So after 1 to 2 years, there may be a contracture in the graft. It will grow hair because you have hair follicles, and there will be sweating because there is sweat glands, and it will have a superior sensory recovery. But the disadvantage is that the donor site has to be closed primarily, which means you're going to have to approximate the edges of the wound of the donor site, or you're going to have to apply a split thickness graft. Okay, these are the various methods of how we obtain grafts in the OR. So it could be by a knife, by a drum dermatome, or by a power-driven dermatome. We usually use the power-driven dermatome. So in the flaps, So flaps are usually, again, tissues of various compositions. So you can have skin, you can have fat, you can have muscle, and sometimes even bone. So it could be skin and fat, muscle and fat, bone and fat, or muscles only. And they have their own blood supply. And this is, again, a high yield question, which means that they don't depend on neovascularization, and you can you can flap a site that does not have a good recipient bed, for example, a cartilage, because cartilages are avascular. So we divide the flaps into three main classifications, which is by the composition, or by the location, or by the vascular pattern. So when we talk about the composition, hence the name, you're dividing it based upon what the flap consists of. So you can have a single composition or multiple compositions. Single could be skin, muscle, and bone flap. Multiple compositions such as faciocutaneous, which is the fascia and the skin, or myocutaneous, which is the muscle and the skin. By location, we have three main types. You have the local. So what the local flap is exactly is that you're obtaining a flap from the donor site that is adjacent to the primary defect to a point they're sharing the same wall, or they're sharing the same border. I have a better image that illustrates this concept in the next slide, so please bear with me. But the concept is that they're having the same border, or they're having the same wall. And this could be, the approximation could either be by advancement, or rotation, or transposition. And the regional flap, as you can see in this picture, you're obtaining your flap in a place that is in the same vicinity, but it's not adjacent to the primary defect. So it's in the same area, but it's not sharing the same border. And this can be moved either by transposition or interpolation. For the distant flap, and hence the name, you're obtaining your flap from a site that is distant from the primary defect. So what's going to happen is that you're going to obtain your flap, and then you're going to have to do a re-anastomosis for the blood vessels at the recipient site. These are the different flap movements classification that we talked about in the local flap. So again, what local flaps are, they are flaps that you obtain from a region that is adjacent to the primary defect, sharing the same border. So as you can see, this is your flap and this is your defect. So they're sharing the same border. So this is the movement by advancement. You're only going to advance this tissue to cover the defect. The same concept here, rotation or transposition. Okay, and then we have the vascular pattern. So in the vascular pattern, we have random versus axial. So I need you guys to focus on this point because it's very important and it's very high yield. So in the random flap, what is happening exactly is that you don't have a specific or a named blood vessel incorporated at the base of the flap. So there's no, as you can see here in this picture, you have a dermal, subdermal plexus. There isn't an identified named blood vessel. This is for the random flap. As for the axial flap, on the other hand, you have a specific named blood vessel. As you can see here, this is the axial flap. The blood vessel is running along its axis. Why is this important? Because there is a limitation for the random flap, which is the length to width ratio. The length to width ratio of a random flap is a 3-to-1 ratio. You cannot go beyond that. Why? Because again, you don't have a specific named blood vessels, which means it will not supply the flap if it was longer or wider than that. It will die off. As for the axial flap, you can go longer than that because again, you have a specific named blood vessel. As for the pedicled versus free flap, the only difference between both is the attachment. What do I mean by the attachment? Is the attachment of the blood vessels. In the pedicled flap, when you obtain your flap initially, it's going to be attached to the blood vessels at the donor site, which means that the flap will remain attached to the body at the harvest site. An example would be, you can imagine a pedicled flap as a dog on a leash. So a dog can move, so you can move the flap to cover the defect, but it's still connected to the leash, which is the connection of the blood vessels to the donor site. I hope this idea is clear because it's very important. For the free flap, on the other hand, you're going to obtain your flap, you're going to disconnect the blood vessels from the donor site, and then you're going to re-anastomose it to the recipient site. So let me show you a picture that would better describe this concept. So this is a pedicled flap. This is what we call the TRAM flap, the transverse rectus abdominis muscle flap. So what happens is that you're going to obtain the blood vessels connected to the rectus muscle with the skin and the subcutaneous tissue and the fat, and then you're going to take it to cover a defect. But hence, it's still connected to the donor site. You did not disconnect the blood vessels whatsoever from the rectus muscle. As for the free flap, on the other hand, this is also known as the radial forearm flap or the Chinese flap. You're going to obtain the skin's subcutaneous tissue, radial artery, and sometimes even part of the radial muscle and also part of the radial bone. You're going to disconnect them from the donor site and you're going to use them to reconstruct your defect. So that's the main difference between pedicled and free flaps. So when we talk about muscle flaps, it's very important to know what muscles can be used as either pedicled or free flap. So what we mean by that is that, for example, we have 5 types. So if we're talking about type 1 flaps, there are muscles that have one vascular pedicle, so one major main pedicle, such as the tensor fasciae lata. This is the major pedicle that we're talking about. It's only one pedicle, and this is excellent if you're going for a free flap. This is what you want. As for type 2, on the other hand, such as the gracilis muscle or gracilis muscle, you have dominant pedicles and minor pedicles. So this is your dominant pedicle right here. These are your minor pedicle. This is what we used in the facial reanimation and Bell's palsy, usually, most of the time. So this is as for type 2. For type 3, such as the gluteus maximus muscle, you have 2 dominant pedicles. So if one pedicle was ruined for whatever reason, the muscle can still function with one major pedicle. As for type 4, which is the sartorius muscle, you have segmental vascular pedicles. This is very important because this muscle cannot be used as a free flap whatsoever, because you cannot depend on segmental vascular pedicles when you use a free flap. As for type 5, which is the latissimus dorsi muscle, you have one dominant pedicle and secondary segmental pedicles. So let's say if you want to use latissimus dorsi muscle as a free flap, you're going to obtain it with its dominant pedicle. You cannot depend on the segmental pedicles per se. Okay, so let's practice together the reconstructive methods. So let's say this patient's presenting with a defect on the tip of the nose. So how would you reconstruct this defect? So the first thing you think about is your reconstructive ladder. First, you start with the least complex, which is secondary intention. So can this wound heal by secondary intention? The answer is yes, it can heal by secondary intention. But first, it's time consuming. Second, the cosmesis is not optimum. It's not the best cosmesis that you can end up with, because basically there are going to be a lot of contracture. The appearance of the nose is going to be altered. So we don't want that for our patient. So we go to the next, which is the primary closure. This is very hard. It's very hard to primarily close this, and even so, it's going to be under tension. And again, the anatomy is not going to be optimum. So we go to the delayed primary, which is the same. It has the same concept as the primary closure. You can do it, but the cosmesis will not be optimum again. For the grafts, whether full or split thickness, so remember, the nose is usually cartilage. It's made up of cartilage. Cartilage is avascular, and we said that grafts usually depend on the vascularity of the recipient site. So again, this is not going to be the optimum method of reconstruction. So let's go to the flap. Yes, flap would be a very reasonable approach in this case, especially if we're talking about regional flaps, axial flaps, such as in this case. This is what we call the forehead flap or the Indian flap. So the main concept is that you're going to take a flap that is in the same vicinity as your primary defect, carrying one named specific blood vessel, which is, in this case, it's going to be our supratrochlear artery, which is 1.5 centimeters from the midline. From right here. This flap usually goes from superficial to deep. So you're going to have a subcutaneous part, and then the subfrontalis part, which is under the muscle, and then the subperiosteal part. And this is what you're going to use to reconstruct your patient's nose. So thank you everyone for listening. Thank you for your time. These are my references. If you have any questions, please don't hesitate to contact me. And I hope you all have a great day.